my name is Amber Goana, and I would like to welcome you to my Med Talk. This is going to be some of the things I pulled from the CPJE California law exam, and as you can see, it's going to be basically like a little Naplex, and so each video is just going to go over each section that I kind of pulled little things from, and I hope you like it. So for this Med Talk, we'll be going over medications that have an FDA approval for the treatment in benign prostatic hyperplasia, which is basically something that males have where their prostate is enlarged. First up here, we have the non-selective alpha-1 adrenergic blockers, and they actually block several types of alpha receptors. They block the A1, 1B, and 1D. The blocking of those alpha receptors is going to cause vasodilation of arterioles and veins, which is going to decrease the total peripheral resistance and blood pressure overall. Titration is recommended every 3 to 4 days. And in general, these medications are not going to reduce the size of the prostate or the PSA level. So for the non-selective alpha-1 blockers, we have terazosin. Hytrin is the brand name. It's 1 milligram daily at bedtime with a max of 10 milligrams a day. And then we have doxazosin, Cardura. It's 1 to 8 milligrams daily at bedtime. The Cardura brand name has an XL version, and it's 4 to 8 milligrams daily with breakfast. But in general, the terazosin and the doxazosin should be taken at bedtime. The next set of medications we have here is selective alpha-1 adrenergic blockers, which is going to inhibit alpha-1 receptors, which relaxes smooth muscles of the prostate and the bladder neck. They are also going to be recommended to take at bedtime, but no titration is going to be required, unlike the non-selective alpha-1 blockers. They also are not going to reduce the size of the prostate or the PSA levels, just like the non-selective ones. So we have alfluzin, urexatrol. It's 10 milligrams daily after the same meal each day, so after the meal. You want to avoid in hepatic impairment, and you definitely do not want to use with strong 3A4 inhibitors. It is known to prolong the QT interval. Then we have tamsulosin Flomax. It's 0.4 milligrams daily after the same meal each day, so again after the meal. The max is 0.8 milligrams daily in non-responsive patients after 4 weeks of doing that 0.4 milligrams daily. It's known to cause ejaculatory dysfunction in some patients. Then we have Jalin, which is actually a combination of dutastride and tamsulosin, so 2 different medications. We also have sildosin. Rapaflo is the brand name for it. It's 8 milligrams daily with a meal. So the other ones were after a meal. This sildosin is with a meal. If their creatinine clearance is 30 to 50 milliliters per minute, you want to max that dose out for the sildosin at 4 milligrams daily. If their creatinine clearance is less than 30, you do not want to be given this to the patient. You also want to avoid the strong 3A4 inhibitors, just like the alfluzin. It is known to cause ejaculatory dysfunction, just like tamsulosin. General precautions with these alpha-1 blockers: they are known to cause intraoperative floppy iris syndrome in cataract operation, and it could also cause erections to last longer than 4 hours in some patients. Some side effects are orthostatic hypotension, dizziness, and cinoscope. So if you stand up too fast, you might get a little dizzy because of that opening of the veins. It can lower your blood pressure in general. You want to monitor their PSA levels, their urinary symptoms, as well as their blood pressure. Next, we have some alpha-5 reductase inhibitors. These are going to block the conversion of testosterone to dihydrotestosterone, and this is going to reduce the size of the prostate as well as the PSA levels. Examples are finasteride, Proscar is the brand name for it. It's 5 milligrams daily. Dutastride Avodart, which is 0.5 milligrams daily. And then again, the Jalin, remember, was a combination of dutastride and tamsulosin, so it's going to have alpha 5 as well as alpha 1. General precautions for all of these alpha 5 reductase inhibitors: you want to avoid in pregnancy. It's actually a category X, so definitely do not want to be taken if you're pregnant. You can take up to 6 months to see the full benefit of these drugs. Some side effects: it could decrease your libido, so your sex drive, it can actually lower it. It can cause impotence or ejaculatory dysfunction, an ED. They are reversible though after the first year, so usually after a year of taking these, the patient may not really experience this ED. It also causes breast enlargement and tenderness. So some patients don't really like it, especially whenever they're a male and they're taking these medications. They don't really want to have man boobs. Some monitoring is your PSA levels as well as their urinary symptoms. And the last class we have here is your phosphodiesterase 5 inhibitors. They are going to inhibit PDE5, and it's going to increase cyclic adenosine monophosphate levels, and it's going to cause smooth muscle relaxation. This is the only FDA approved for BPH. It's tadalafil, Cialis is the brand name. It's 5 milligrams daily at the same time each day. If the patient has a creatinine clearance of 30 to 50, or if they're on CYP3A4 inhibitors, you want to max their dose out at 2.5 milligrams daily. If their creatinine clearance is less than 30, you just want to avoid this medication altogether. A general precaution: it is known to cause hearing loss, impaired color, or just vision in general, prolonged erection, and pyroplasm, which is a very, very long erection. Side effects include headache, flushing, dyspepsia, so it can be heartburn, hypotension, nasal congestion, blurred vision, and back pain. You want to monitor the patient's blood pressure, PSA level, and urinary symptoms, just like all the other ones. And that is all the listed medications they had that were FDA approved for the use in BPH. Again, my name is Amber Gawana, and I wish you the absolute best of luck in all your studies.